So this is a case of a dropped 3-piece lens. The first thing to do is to salvage it from the vitreous cavity before dropping onto the macula. Here an end gripping forceps is used to externalize this haptic. It's safe that we put this haptic outside the eye so that it acts as a hinge for manipulation of the IOL in the direction needed. Of course, here there's a side port. Using the spatula to support the IOL is helpful. So the next step after externalizing the haptic is to put an AC maintainer, because this eye is partially vitrectomized, and then inserting cannula 3.5 millimeter from the limbus. Then after that, we can use the cannula to insert the spatula to support and levitate the IOL from behind. And after internalizing the haptic again, putting it above the iris into the AC, we can manage this IOL to dial it and dial the second haptic to the AC. It's important that these haptics are in the inverted S manner so that we can, as you know here, there is no capsular support, so we can proceed to doing the Yamani technique. The first thing is to mark the center of the cornea by measuring the horizontal diameter of the cornea and the vertical diameter, and then using this center to mark the 180 degrees, and then 2 millimeter horizontal, 2 millimeter vertical, and then using the insulin syringe, which is a hypodermic 27 gauge insulin syringe, to move 2 millimeter vertical and then horizontal. After the insulin syringe is internalized, we use the curved end gripping forceps here to grasp the leading haptic, and then leading haptic now is then externalized. But here, before externalizing the haptic, we leave the syringe, the knob of the syringe inside, and it's stable, it doesn't hurt the retina, to keep the haptic within the tunnel, and then going for the trailing haptic. The trailing haptic is a bit tricky, so one tip here, of course, putting viscoelastic, one tip here is to use the end gripping forceps and the syringe itself to push it away to allow a grip for the trailing haptic. Here, this part of the video is unedited. It shows that sometimes it's difficult to mobilize this haptic and to insert it into the syringe. Sometimes the haptic gets caught up in the forceps, but if we grasp the haptic 2 millimeters away from its tip, it's very easy to manipulate it. And as you can see here, the IOL is a bit tilted towards the other side, but there's no problem of the haptic does not slip from the insulin syringe, which is embedded into the sclera on the other side. Now the trailing haptic is now inserted into the insulin syringe. Then this syringe is gradually externalized. As you can see, slowly and surely, this haptic is externalized outside by doing some counter force on the globe and pulling the syringe gently. Now cauterizing 1 millimeter of the tip of the haptic, and then before burying the tip of the haptic, we externalize now the other haptic and we cauterize also 1 millimeter. A tip here is that we bury both haptics together slowly, because if there is a bit decentration, we can manage in this particular step before burying the haptic in the scleral tunnel and losing any way to do more centration. Looking at the retina, of course, will be okay with some scleral indentation to be sure that there are no breaks. And now the surgery is now concluded. And thank you so much, and waiting for your comments. Thank you.